Hello, everyone, and good afternoon. Hope you're all doing great today. Thanks for joining us, and we want to welcome you to today's San Bernardino County Medical Society webinar presentation. Oops, I grabbed the wrong one here. Just a moment. Long COVID, who's most at risk, and do vaccinations help prevent long-term illness? I'm sorry, I've got a frog in my throat. I'm Allison Elsner, and I'm the CEO of San Bernardino County Medical Society. This webinar is the fourth in our series of 7 that the Medical Society has been hosting and will continue to host between now and next spring, made possible by a very generous grant from the San Bernardino County Department of Public Health. Before I introduce our expert presenter today, I just want to remind you that you're all welcome to submit questions as the presentation goes along, and you can do that either via the chat feature on your Zoom screen or when our speaker has finished. Go ahead and feel free to click the raise hand icon on your dashboard. And of course, if you're not speaking, we appreciate you keeping yourself on mute. All right, I'm very honored to introduce today's presenter, Roger Schwelt, MD. Dr. Schwelt is a pulmonologist with Beaver Medical Group in Banning. He's also associate clinical professor at UC Riverside School of Medicine and School of Medicine and Allied Health at Loma Linda University School of Medicine. In addition to being a preceptor for PA and medical students, he was the medical director for the Physician Assistant Sciences program at Loma Linda School of Medicine, for a sleep lab in the area, and for the Crafton Hills College Respiratory Care Program. He is certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine through the American Board of Internal Medicine. Dr. Schwelt was the recipient of the 2021 San Bernardino County Medical Society's William L. Cover MD Award for outstanding contribution to medicine. Yay, we loved presenting that to you, Dr. Schwelt. That was a special moment. And many of you are familiar with Dr. Schwelt and his work through his very popular educational video platform presentations, MedCram, which he co-founded in 2012. MedCram is a medical education company with CME accredited videos that are utilized by hospitals, medical schools, and hundreds of thousands of medical professionals from all over the world. And he has over 1 million YouTube subscribers. That is really saying a lot. His passion is promoting healthy lifestyles and regularly lecturing to schools, hospitals, and media outlets. And much of his messaging over the past 2.5 years has focused on demystifying the various aspects of COVID and related treatments. So Dr. Schwelt, we're so excited to have you, and we're going to turn it over to you right now.
Well, thank you so much. I really appreciate being here and being invited to talk about this. We're going to talk about exactly what's in the title, who's most at risk, and do vaccinations help prevent long-term illness. But we're also going to talk about practical things that healthcare providers can do when their long COVID patients come and present. So without any further ado, we're going to move through things pretty quickly. Some of this stuff might be a review for many of you, others maybe not so much. Can you all see that screen then? All right, very good. Okay, so let's get started. These are our learning objectives and disclosures. So the long-term effects of COVID-19 is very, very broad. You know, I just gave a lecture today, and one of the medical students asked me, is it possible that the long-term COVID effects of COVID-19 could be very similar to the long-term effects of people with ARDS? And they had a point there, because a lot of the things that we were saying with ARDS was very similar to COVID-19. They have lung issues, they have difficulty breathing, maybe brain fog. But I believe that because there's so many more people that have come down with COVID-19, we're actually seeing a wider variation because of more people. So as you can see here with this chart, there are so many things that can be affected with long-term COVID, probably because the virus affects so many different parts of the body. But some of the things that you can see there that are pointed out: fatigue, 58%, headache, 44%. And then the rest are less, but also significant breathing issues as well. And so what do you do with these patients? It seems like it's a nebulous thing. You don't really know exactly what to do for them. How can we actually start to break down and find out some of these things and actually help our patients? So the first thing we need to do is come up with definitions. So this term of long COVID, post-acute sequelae of SARS-CoV-2 or PASC, post-acute COVID-19, a lot of these terms are thrown around. But the definition is that it's greater than 12 weeks of symptoms during or after COVID-19. And so that's an important thing to understand, is that definition of 12 weeks. That's about 3 months. So realize that patients have to have more than 3 months of symptoms before we can really call them persistent COVID-19 or long-term persistent COVID-19. And this has to be explained by something other than a diagnosis that we could already make, like a blood clot, which we'll talk about a little bit more. Again, the length of symptoms can vary. Sometimes these patients go in, are outpatient or inpatient. Well, typically the ones that we see with these type of long-term symptoms are the ones that were very sick and the ones that are inpatient. And it also depends on the kind of symptoms that we're talking about. Fever is something that is very short-lived. It's very rare that people have long-term fever. But on the other hand, shortness of breath is something that people have even months, maybe even a year or so more after the initial infection. So we started getting some data out on this back in early 2021, 2022, et cetera. This was a study that was published here looking at Swedish patients, about 300 of them, and they looked at symptoms. So 26% versus 9% had these functional and impairments 8 months after having mild COVID-19 among healthcare workers. At 8 months, it was 15 versus 3%. And they said here that 8 to 15% versus 4% said that it interfered with work, social, or home life. And this is something that's not a stranger to us as healthcare providers. We see this. Here's another study that was done, this time on 1,600 patients in the United States. This is 60 days after discharge from a hospital. 33% had persisting symptoms, 19% worsening symptoms. And what were the biggest ones? Dyspnea, chest pain, chest tightness, shortness of breath, cough, loss of taste or smell, which we'll get back to in a little bit. And this was published in the Annals of Internal Medicine. You can see the references there. So looking at these references as sources of information, we can come up with some common physical symptoms that we see here after COVID. Notice that fatigue seems to be the one that lasts the longest, and it hits the 3 months. And that's the reason why fatigue is such a common symptom in people who have symptomatology after 3 months' time. Dyspnea, chest discomfort, cough. No smell or taste is another common one. Sometimes people have altered smell or taste, which is more common than just the 10 to 13% here. So we're going to tackle some of these things today in this lecture about what we should do. What's the evidence say we ought to be doing? Some less common physical symptoms, less than 10% incidence, you can see there: joint pain, headache, Sika syndrome, rhinitis, perception of taste, and the list goes on and on. Even alopecia, which we'll talk about, that's hair loss associated with COVID-19. A lot of people have had that experience. Why would that be? We'll talk about it. Common neurological symptoms that we see: PTSD. I mean, if you had to go into the intensive care unit and you thought your life was going to end, potentially, obviously, this is not a no-brainer. This is a no-brainer here why they might have PTSD, but certainly impaired memory, poor concentration, and anxiety and depression. All of these are very common signs, and they last up to even a month, up to 2 months even, in patients with post-COVID-19. So let's look at some of the outcome measures in a cohort that was recently published. This is a prospective cohort from 2 hospitals that filled out questionnaires in Vancouver, Canada. All patients were discharged from the hospital with SARS-CoV-2. They're about 3 months out. They sent these questionnaires out to 101 people. 78% of them filled them out. 51% of them said there was a quality of life reduction. 50% had dyspnea, 23% had cough. The problem with this study, though, there was no baseline to compare it to, but significantly increased risks of all of these sort of things that are concerning. So let's go to your waiting room. What do you do when someone actually comes in to your waiting room and has these kind of issues? So first question is who should get follow-up? Who needs to get follow-up? I think this is some good evidence for you out there that are practicing in these kind of situations. If someone is younger, have no comorbidities, and they had this as an outpatient, there's no reason to see these patients back unless they actually have new symptoms. Okay. If they were younger and they had no comorbidities and they were hospitalized, probably should see them back in a week. In fact, anybody hospitalized should be seen back within a week to make sure that symptoms are improved. There's a lot of stories and anecdotal evidence of people getting worse even a week out. So if someone's been hospitalized for COVID-19, you should be getting them in within a week. But if they're older and they have comorbidities and they had it as an outpatient, these are the people that we shouldn't be dropping. We should see them back within 3 weeks. And we should get information about their symptoms of COVID-19. How was it treated? What was the duration of illness? Were they intubated? Were they not intubated? These are the sorts of things. The one thing I should mention is there's absolutely no need to retest them for SARS-CoV-2. It's not going to change their management regarding this. By that point, they should be negative, unless, of course, they have lingering symptoms, but you don't need to routinely check for SARS-CoV-2 on a routine follow-up. All right, let's divide the talk up into cardiopulmonary, neurological, blood clotting, olfaction, and fatigue, and then a couple more at the end. But let's go through here and talk about some of these long COVID effects. Let's talk about cardiopulmonary. This is what I ask about. This is what we should ask about when patients come back. You know, what we're trying to do is trying to make sure that they don't have some other side effect of COVID-19 or some other effect that has been caused as a result of the viral infection. So do they have congestive heart failure? We could ask them about shortness of breath when they're lying down. That's orthopnea. We ask about cough, wheezing, chest discomfort at rest when breathing, swelling in the lower legs. That could be a result of a pulmonary embolism. Palpitations, that could be from arrhythmias. So basically, taking a very good history in the cardiopulmonary district is really important. What about getting a chest x-ray? How soon should you get a chest x-ray? Well, here on the left is an x-ray from somebody who had progressive symptoms of COVID-19. What we ought to do is we should not get those chest x-rays too quickly, routinely. Obviously if something's getting worse or the patient has persistent symptoms, get imaging. But it takes about 12 weeks for those x-ray findings to disappear. And you do want to make sure that they disappear. You want to make sure that there isn't a mass or some sort of infiltrate that's hiding under all of that COVID-19 din there on the chest x-ray. So I recommend waiting about 12 weeks, repeating a chest x-ray, making sure that it clears up and it goes back to normal. Obviously, an ECG is a really easy, low-hanging fruit. It's very cheap, and it can pick up a lot of stuff, including atrial fibrillation, including a myocardial infarction that the patient may have suffered during that time. Getting an ECG is a good idea, so I think that's reasonable. If the patient has concerning symptoms of lower extremity swelling, that's new. Obviously, the concern for echocardiography or bilateral lower extremity DVTs is important in getting an echocardiogram. You may even decide to get enzymes, but you may want to consult with a cardiologist at that point, since you're going to be reading it anyway, to see if that's a reasonable thing to do. Okay. All right, something that's near and dear to my heart, literally, is my lungs, and also pulmonary function test. That's how we check the lungs. So it's well known that people who are hospitalized on ventilators and have COVID-19 can get fibrosis, and that can reduce your pulmonary function. So getting a pulmonary function test is a good way of documenting that and making sure, especially if there's a baseline before, how much lung function have they lost. So in the outpatient clinic, that's a reasonable thing to do. Not only are checking lung function, but also lung volumes and also the DLCO. The reason why the DLCO is important is that DLCOs will be dropped, they will be reduced significantly if a patient has developed chronic thromboembolic pulmonary hypertension. And that can happen in patients who have DVTs that are undiagnosed. They can set up shop, they can become complicated, and the patient can develop severe symptoms of pulmonary hypertension as a result of that. You will pick that up on a pulmonary function test potentially with a low DLCO. Of course, a DLCO can be low for a bunch of reasons, but if it's in isolation, you need to consider that as well. So when do you refer to a specialist, and what do we do? Well, what I do in my personal experience is D-dimers are helpful, because in the outpatient setting, if a patient is having dyspnea and they have a positive D-dimer level, that encourages me to go down that pathway of making sure they don't have chronic pulmonary embolisms. If, on the other hand, the D-dimer is negative, it's extremely rare for somebody to have any kind of thromboembolic problems. Things that you can also do is getting bilateral lower extremity ultrasound Dopplers to make sure there's no DVTs in the lower extremities. And then I'll say this, I'll say VQ scan. And I know the common practice is to get CT angiograms. The problem with CT angiograms is that they're very good at looking at acute and large centrally located pulmonary embolisms. They are not very good at looking at chronic peripheral pulmonary embolisms. And that's typically what we see in patients with long COVID. They'll get pulmonary thrombotic pulmonary complications. And so if somebody has lower extremity swelling, they have elevated pulmonary artery pressures, and they've had an incident that's happened months ago, my first choice is not to get a CT angiogram. It's in fact to get a VQ scan, because that is much more sensitive for the small clots that you're concerned about in that situation. And actually that's based on data that goes back decades. Methacholine challenge test is certainly people who have viral infections can develop sensitivity to reactive airways disease, asthma, things of that nature after a viral infection. So if you have a normal pulmonary function test, don't stop there, get a VQ scan as well. And then of course you can get complete metabolic panels to check for creatinine, bicarbonate, VUN, things of that nature. Okay, that's the cardiopulmonary area. Let's talk about neurological. So there's a lot of studies that have been now linking people with COVID to really concerning brain outcomes. There was a biobank study that was done, showed in 785 UK biobank participants that showed that those with COVID had greater reduction in gray matter thickness in orbital frontal cortex and parahippocampal gyrus, greater changes in markers of tissue damage in regions of olfaction, greater reduction in global brain size, and a larger decline in cognition. Now, this is an association, so we don't know whether the COVID infection caused this or whether or not people with smaller gray matter are more influenced to get COVID-19. I think that the latter is pretty unlikely. And in fact, that it's very likely that COVID is actually causing these sorts of things, just based on the sort of things that we're talking about. Now, interesting. So what would I do here? I don't have a randomized placebo-controlled trial, but it's interesting to me that the very things that we see here are happening in patients with COVID that are a shrinking of the brain, a shrinking of the gray matter, a shrinking of the size of the brain. It's really interesting to me that independent research has shown that people who get out into the sun and get more sun exposure and exposed to near infrared radiation, ultraviolet radiation, things that can produce vitamin D, and some scientists believe melatonin in the mitochondria, that these sorts of things are actually associated with the opposite, an increase in gray matter, an increase in brain size, both in people with multiple sclerosis and in controls. So what I've been telling my patients to do is not necessarily to get outside and to get sun exposure, but to get outside and get indirect indirect sun exposure, especially now in the wintertime when that's so rare. Like as healthcare providers and as patients even, we get up in the morning and get off to work before the sun gets up, and we're home already after the sun is down, and we're really getting very little sun exposure. And I just don't think that that's very good for our health. And so I've been telling my COVID patients, my post-COVID patients who are ill, get outside, get some fresh air, get some sun exposure, especially now in the wintertime when it's at a minimum, because we know that this is when depression and respiratory illnesses are worse. And I think it has a lot to do with sun exposure. In terms of neurological, a complete neurological history and examination is important. Consider imaging only if focus depends on the present, if deficits are present. So in other words, if there's focal deficits that you're seeing, get imaging. If it's global, that's not necessarily a reason to get imaging. And then consider neurocognitive testing, because that's much more sensitive in terms of picking up some of those things that we're talking about. All right, let's move on to blood clotting. This is a big issue. We knew this very early in the pandemic. People who get COVID are 19 times more likely to have blood clots in the lung based on autopsy reports. This was published in the New England Journal of Medicine. So a careful examination with respect to CT, PA, VQ scans, bilateral lower extremity ultrasound, looking for blood clots. If you find a blood clot, I would probably at that point say that you're dealing with a provoked blood clot. So COVID-19 provoked the blood clot. And the reason why that's important is, just generally speaking, if we have blood clots, we have to determine whether they were provoked, whether we can find a reason for them, whether it was surgery or a long car trip or an airplane flight, versus those that are unprovoked. And the reason why that's important is because when we treat people with anticoagulation who are unprovoked and we stop it after 3 months, their risk for getting a reclot is much higher than those who were provoked and we remove the provoking factor. So that's important to understand. In other words, finding out whether or not the blood clot was provoked by something that we know and can remove has a lot to do with how long we treat these patients for. So if your patient had a blood clot and we believe it was temporarily associated with COVID-19, there's different recommendations on this. My recommendation would be at least 3 months. Some people I've heard even 6 months, and then stopping the anticoagulation at that point to see how things go. But I think it's a reasonable thing to do, especially for this. And I've seen at least 3 or 4 patients in my own clinic who have had blood clots related to COVID-19. Let's talk about olfaction. So this was a big deal early on. People would say, you know what? The first thing I knew that I had COVID was I walked in and I could not smell the burning pot on the stove. And I knew that that was a problem. And that's actually a safety issue, right? If you can't smell smoke, you can't get out of the house. And so notice here that in our common physical symptoms, 10 to 13% of patients who had COVID, long COVID, I should say, had no smell or taste. But notice that there was a good majority of them that got it back by 1 month. This statistic here is not telling you everything, because there's some people that even up to this point don't really have gotten all of their smell and taste back like it was normal. It's still like they'll say, hey, that food still tastes like that, or it's that smell still doesn't quite, it's not quite exactly the way it should be. So what do you do for these people? And I always scratch my head because I'm not an ear and nose and throat doc, and I don't know a lot about olfaction, but I researched it and I found some really interesting research. So this is not unique to COVID-19. This is not unique to long COVID. Any kind of viral infection, in fact, can cause very similar symptoms. And in the research with COVID-19, if we look at the olfactory epithelium, the research has been done that the issue is actually not with the neurons itself. That's good news, because neurons can't really regenerate very well. The problem is not with the neurons, but rather the nurse cells around it, or the supporting cells that get damaged from the movement of the virus. The virus does not infect the neurons in this case. The neurons are not being touched. It's actually the support cells that are being infected, and that's causing this alternative taste and smell. So here's a paper that was published in the prestigious journal Science, saying that single cell sequencing revealed that ACE2, which is the receptor for SARS-CoV-2, is expressed in support cells, just like we said, stem cells and perivascular cells, rather than in the neurons. Immunostaining confirmed that these results and revealed pervasive expression of ACE2 protein in dorsally located olfactory epithelial sustenticular cells and olfactory bulb parasites in the mouse. These findings suggest that SARS-CoV-2 infection of non-neuronal cell types leads to anosmia, that's loss of smell, and related disturbances in odor perception in COVID-19 patients. Okay, so again, let's look at our nerves here. We see the nerves, and we see these olfactory neurons, which is these pink cells here. Well, it's these supporting cells or nurse cells that are green here that are interdigitating between these neurons. Those are the ones that are being damaged, and when they're damaged, the other cells are not working as effectively as they should, and that's what's causing the problem with it being able to smell. Okay, so what do we know? It usually gets better on its own, but not always. It rarely lasts for more than a month. But if it persists, the recommendation is to seek out an ear, nose, and throat specialist for something called olfactory training. So this interested me. I was like, well, what is this olfactory training? Well, the story of olfactory training is actually quite remarkable, and it's something that you may be able to do on your own. Let me explain to you what it is. So here's an article that was published in clinical tips hearing, saying that olfactory training in COVID-19 related loss of smell. So what is this person doing? They're sniffing something here. Would you believe they're sniffing essential oils? So for most of you out there, when I say essential oils, your first reaction for some of you may be like, oh, cool, essential oils, because you grew up with essential oils and you know about it and you're like, yeah, that's cool. The rest of you might say essential oils. Okay, this is the essence of quackery here. This is what my patients who don't believe in medicine use. Well, I'm going to surprise both of you here. Okay, so I'm going to actually look at essential oils, and we're going to use the highest level of evidence. Okay, so open your mind here. Don't close your mind. We're going to look at the highest level of evidence, which is randomized, placebo-controlled trials and crossover. And I'm going to show you that there may be a role for essential oils in olfactory training. But to begin that, I got to sort of set up the story here. So there's something called sniffing sticks. These are little markers that are marketed in Europe, and each one of them has a specific sense and smell. And these otorhinolaryngologists basically came up with a way of assessing your ability to smell. So before we can see whether or not something works, we have to come up with a standard. And so they came up with a standard looking at T, the ability to have a threshold of smelling, D, a discrimination score, and I, an identification score. So first of all, can you smell it? How strong does it have to be able to smell it? Number two, are you able to discriminate between two smells? And then finally, are you able to identify, yeah, this is cherry, apple, red, or no, this is grape, or no, this is, whatever it happens to be. So they came up with a score where they combined all three of those, and they said here that a score of less than 16.5 is you can't smell at all, 16.5 to 30 is you're smelling a little bit, and then greater than 30.5 is you're smelling too much. So here's the key point from all of that. They said that a change of greater than or equal to 6 points perceived by 60% of subjects represents a real improvement in olfaction. Okay, so that's what I want you to remember, is that they came up with a way of saying, hey, is this actually making a difference or not? Okay, so now we know what the endpoint is. Let's see what they did. So here's a study that was published back when they had patients with viral infections that caused them to lose their ability to smell. And they had 35 patients in this PISL. This is post-infectious loss of smell loss, okay? And 35 patients, 24 in the intervention group, 11 in the placebo group. And what they did was they exposed these patients to 10 seconds of smelling an essential oil of rose, eucalyptus, clove, and lemon. Okay, and they did it twice daily for 3 months. And their endpoint was this TDI score improvement of greater than 6 points. So how many of them actually reached that endpoint? Well, in this randomized controlled trial, 21% in the intervention group got better, and it had actually improvement, versus 6 in the placebo group. And that was statistically significant. So what the scientists believe is going on is that you're retraining. So you know what you're smelling. That's the key that you have to understand. You know that you're smelling rose and you're smelling the essence of rose. And what you're doing is you're reprogramming your ability to smell to your brain so that the neurons start to adapt to that. You know what eucalyptus is supposed to smell like, and therefore you're smelling it. And so basically what you're doing is you're recalibrating your ability to smell. And the studies show that this may actually be beneficial. Here's another randomized controlled multi-center study. Folks, randomized controlled trials are the highest level of evidence that we have. It's what the FDA uses to give approval to FDA vaccines and medications. And in this case, it was even more rigorous because they did a crossover trial. So here we have the intervention group, and they use rose, eucalyptus, clove, and lemon. And what they did here in the placebo group is they used the same essential oils, except they diluted it down so infinitesimally so that you couldn't even tell what it was that you were smelling, okay? And what they noticed is that 144 patients, so this is a bigger study, that 26% of them had the endpoint, whereas only 15% in the placebo had the endpoint. Remember that people get better on their own, so it's possible that they're getting better without the intervention. But then what they did was they switched groups. So maybe there was a problem with the randomization. They switched groups. And those people that had the very same people that had a minimal improvement in the placebo had a greater than 20% improvement in the intervention group, whereas those people initially that had an improvement of 26% in their intervention had only a 16% improvement in the placebo. So this is a double-blinded, randomized, placebo-controlled crossover trial. Folks, the evidence can't get any better than this. This is pretty dramatic. And what did they show here? That 63% of the people responded before 12 months of symptoms, whereas only 19. So the point is that if you want to do this kind of olfactory training, this is what happens in the ENT office, you got to do it early, and you need to get it done. Otherwise, there's the point where if you don't get it trained, there's some people that aren't going to get the benefit of that. So what are the side effects of this? 8% rate of minor side effects, including nose bleeding, nasal burning, and hay fever. So that's a potential possibility, especially if you're allergic to some of these oils, okay? Here's another study where they did it again, another study. This time they decided to say, hey, maybe rose, eucalyptus, clove, and lemon isn't the only thing we should use. So they decided to do 3 different types after 3 different months. And they noticed that had the highest improvement, 56% in this group versus 0 in the placebo, and 46 in the ones that just used rose eucalyptus. So it could be that more data points for your brain is better. So, but I would recommend that if somebody is losing their sense of smell or hasn't gotten it back, that olfactory training may actually, well, I think it's very definitely has proven itself as being of benefit. Here's another one. Again, if you stop doing it after 4 months, 58%. Those that continued up to 13 months with this training even got better, up to 71% had an improvement, a real improvement as defined by those sniffing sticks that we talked about, and that was statistically significant. Okay, so that's olfaction. What about fatigue? So this is the most common thing that we see, patients with fatigue. Some of the tools that we can use, 6-minute walk test, the EuroQual 5D, timed up and go, short physical. These are actual assessments that you can do to measure fatigue. Fatigue is really hard to measure. But I would say this, for my patients that are fatigued, make sure they are getting adequate rest. We are living in an epidemic right now of lack of sleep. People are not getting enough sleep. And I can't tell sometimes whether or not that fatigue is a result of the viral infection, the fact that they're not getting enough sleep, or both. And what I mean by good sleep is I mean you're getting at least 7 solid hours of sleep. And the only way you can really do that is if you get to bed nice and early and turn off the lights. That's a big problem that we have in this country is turning off lights after 9 o'clock. This turning of night into day is a wretched, health-destroying habit, in my opinion. And maybe I'm acutely aware of that because of my own life. It's difficult for me to go to bed. And I know I feel better when I get a good night's sleep. And also maybe because of my training in sleep medicine. So highly recommend getting at least 7 hours. If you're less than 18 years of age, that number goes up. You need to be getting 10 hours of sleep if you're a high school student. And they unfortunately usually get less sleep than we do because they're up at all hours of the night and they're studying, and that's really not good for their body. So fatigue is, let's talk a little bit more about fatigue because there's been some recent studies. But before I do, we promised here at the beginning of the title that we were going to talk about vaccination for long COVID. So let's look at the data for vaccination for long COVID. So this was a study that was published early called The Efficacy of COVID-19 Vaccination on the Symptoms of Patients with Long COVID, a target trial emulation using data from COMPARE e-cohort in France. Let me show you what they did here. So this is kind of my own drawing here. Here's the COMPARE cohort in France. And here are people that got long COVID. So at least 3 months of long COVID, that was the definition that we talked about at the beginning, and they have at least one symptom. And then as they got vaccinated, one by one, okay, with any number of the vaccines that are approved in France, there was 455 of them. What they did was they assigned each one of these people that got vaccinated in the cohort a unvaccinated control, okay? So they paired it to age, they paired it to weight, they paired it to socioeconomic, all of those things that they could pair it to. So essentially what they did as time went on is they had two cohorts. They had the vaccinated intervention cohort, which was 455, and they had the unvaccinated control, which is also 455. Now, what were the vaccines in this? 78.9% were Pfizer, 10.3% were Moderna, 0.2% were Johnson & Johnson, and because this was in France, they had approval of the AstraZeneca vaccine, which was based at Oxford, Cambridge, can't remember which one, in London, and that's 10.5% that got that. Then they looked at two things. They did a questionnaire at 60 days and at 120 days, and they looked at COVID symptoms, and they looked at the impact of those symptoms on COVID life. So what do they find? Here's a table directly from the publication, and they looked at long COVID ST scores at 120 days with the mean. So in other words, the lower the score, the better. So in the vaccinated patients, it was 13, and in the unvaccinated controls, it was 14.8. So there was a slight reduction. What about remission of long COVID by 120 days? 16.6% remission at 120 days in the vaccinated, and in the unvaccinated control, 7.5%. So that was a little bit more of a switch there. This sort of goes along with the theory that potentially at least some long COVID patients may be represented by the fact that the COVID is hanging out in the body using molecular mimicry. In other words, the virus is making itself look like the body. And as a result of that, the immune system is not able to quickly identify it and get rid of it. This is the same process that streptococcus does in, for instance, in scarlet fever and in post-streptococcal glomerulonephritis and things of that nature. As it hangs around, and finally antibodies are made against the strep, and then they cross-react with the body. So that may be what's going on. Look at this IT score for COVID, 24 here. It's lower in the vaccinated, slightly higher in the unvaccinated controls, and then proportion of patients with long COVID IT score greater than PAS at 120 days. And you can again see here, it's lower in the vaccinated versus the unvaccinated control. So there is a difference, and it is statistically significant, and it may not be the answer for everybody because people may have long COVID for different reasons. There were some severe adverse reports in the vaccination arm, but unfortunately they didn't have those in the control because they assigned the control. So don't know exactly if these, it'd be nice to know if these were the same in the control group as well. In terms of the rate of complete remission, we can see here in the vaccinated patients, that number kept on going up, whereas there was a plateauing in the unvaccinated controls. So this is not a randomized placebo-controlled trial. So this level of evidence is not the highest, but it is a sort of a observational study, which does give some information. There is some weight to it, but again, it's not a randomized placebo-controlled trial. So just be aware of that. Here's another study that was done, post-acute symptoms 4 months after SARS-CoV-2 infection during Omicron period, a nationwide Danish questionnaire study. So here's another questionnaire study. And what did they do here? They did a questionnaire-based cohort study with outcomes on post-acute physical fatigue, cognitive mental health symptoms, and new onset general health problems 4 months after testing. Okay, so that meets our criteria that you have to be having it for at least 3 months. Risk differences were estimated by comparing cases and controls during the Omicron period. So again, this is not a randomized placebo-controlled trial. This is an observational trial looking at controls. And they controlled for age, sex, BMI, self-reported chronic disease, et cetera, et cetera. What did they find? A considerable amount of cases infected during Omicron period experienced post-acute symptoms and new health onset problems 4 months after testing, although milder compared to Delta cases. Okay, so that's good news. At least the long COVID symptoms seem to be less severe with Omicron. They go on though. During the Omicron period, a booster vaccination dose was associated with fewer post-acute symptoms and newer onset health problems 4 months after infection compared to 2 doses of COVID-19. So in other words, if you had 2 doses of COVID-19 and still came down with COVID and had long COVID, getting an additional booster at least seemed to be associated with having less symptoms. Now, again, this is association doesn't necessarily mean causation. It could be that the people who are more apt to get a booster may also have had some other factor that caused them to have less COVID-19 long symptoms. Again, I think it's at least, at the very least, it's hypothesis generating. And it seems to go along with at least the theory that long COVID may be due to, again, the virus hanging out in different parts of the body. And what the vaccination may do is stimulate the body to completely wipe it out and clean it up and get rid of it. In terms of vaccinations per day, I put this out there just to give you a context. Sometimes we need to sort of zoom out at the 30,000 foot level, and sometimes we don't get a chance to do that. And then I'll sort of wrap up here real quickly because it's getting on to 1 o'clock and we want to take some questions and get done by 1:15. But what I wanted to show you here is if you look at, this is the United States, and we're looking at the number of cases of COVID-19 down here on the second graph. I don't know if you can see my arrow moving around here, but that's where I'm talking about here, okay? So these are cases, and this big bump right here is Omicron, okay? We had a lot of people get Omicron. Now, if we look at COVID-19 deaths per day, that's here on the second from the bottom, the orange one, it almost completely mirrors cases, and that should not be surprising. COVID-19 cases, of course, leads to COVID-19 deaths. Now, these are on different scales, by the way. This is probably 100 times bigger than this one here because about a 1% mortality. But if you look at excess mortality, even in the youngest age group, 16 to 64, you can see that excess mortality is almost perfectly explained by COVID-19 deaths. Okay, so that's just empiric data. What I want you to, and this, we've seen this all before, but what I want you to notice is this graph up here, which is vaccinations per day, is on the same scale as cases per day. I want you to realize the number of cases that we were having of COVID-19 per day is in the 100,000, 200,000, 300,000 level, which sounds like a lot, and it is a lot, especially when you consider the number of deaths. But remember that we were vaccinating at our peak 3.5 million people a day. Okay, so the highest that we ever got here was maybe 300 in this area here, 300,000 people a day coming down with COVID-19 or SARS-CoV-2. At the same time, we were vaccinating 3.5 million people a day at our heights. Now, I want you to notice here in terms of COVID-19 deaths per day, excess mortality, and look at these graphs and ask yourself, I'll let you decide for yourself. This is just the raw data. And remember here that deaths per day is pretty robust data. Like if somebody dies in the hospital, you cannot put them in the ground without a death certificate. That's where this number is coming from. If somebody dies at home, you cannot put them in the ground without a death certificate. And we're not even talking about what they put on the death certificate. We're just saying that there is a death certificate. So these numbers here are pretty robust. They're not going to be manipulated in any kind of way. This is the total numbers. So you can make a decision here whether or not it's vaccines that are driving COVID-19 deaths or excess mortality, or whether it's deaths or COVID itself. And you can make that determination, at least here in the United States. I just pulled this off of Our World in Data. And I think that the key here that I'm adding to this is understanding just on orders of magnitude, more people getting a vaccination than getting COVID-19, and trying to put that in to explaining the excess mortality. So let's talk about hair loss. This is something that, boy, I have gotten more thanks for my videos. Out of all the videos that I've done, the more thanks I've got for this, because people are literally freaking out because their hair is falling out. And for them to find out that it's perfectly normal after COVID or any kind of stress on them, and the fact that it's going to come back exactly the way it was, and it's not like they're losing hair and it's never going to come back, that is very, very reassuring to people. So this is what I show them. There's 4 different phases of your hair. The problem is that your hair is in all 4 different phases, all at different times. And so what happens is when you get stressed, your hair follicle in the active phase from 2 to 6 years, there's going to be some hair on your head that is not in that phase. Okay, they get advanced to the telogen phase. And in the telogen phase, there's no more blood supply. You can see here, there's a blood supply. Here, no more blood supply. The dermal papilla is separated from the follicle. And then what happens is in 3 months' time, here we can see the hair falls out. And so what happens is when your hair is falling out, you have no recollection, or you don't even remember what it might have been that you had 3 months ago. You've forgotten that you've had COVID. But it's usually like this. You get COVID, you're sick as a dog, and you're fine. And then 3 months later, your hair starts to fall out and you're like, what has just happened to me? And the good news is that the hair, after this happens, guess what? Here's the good news. After it goes from the anagen phase, it goes right back. Sorry, after it goes through this telogen phase, it goes right back to the anagen phase and another hair pops out and you get your hair back. So this is something, if your patients are complaining about their hair falling out and you've ruled out hypothyroidism and you've ruled out other diseases that might be associated with this, autoimmune conditions, if it's related to, if there's this history of COVID 3 months ago, I would reassure them that it's going to take some time, but the hair is going to come back. All right, so we've talked, I've already talked a little bit about light and sunlight, and it's already 1 o'clock, but I'm just going to show you this. This is really, this just got published a couple of days ago, actually. And what does it show? It shows, if you guys are familiar with the mitochondria, this is where the evidence is now looking at that there is, that the mitochondria themselves may actually be impaired in long COVID. And specifically, and you guys know the mitochondria is the powerhouse of the cell. It's an organelle in the cell. And one of the things, obviously the 3 types of food that you eat, or 3 types of energy that you process, are fats, sugars, and proteins. And they all enter this thing called the citric acid cycle. TCA, Krebs cycle. Those of you who went to medical school know that we had to memorize this at one point. Thank goodness we don't need to know it anymore. But the point here is that fats have to come from outside the mitochondrial matrix, and they're transported in with this thing called acyl carnitine, and they come in. Well, what they're finding now in this study is when they compared healthy people to post-COVID people to people with long COVID, here on this graph, they're noticing that the metabolites in the Krebs cycle are greatly reduced, not only in post-COVID people, but also in long COVID people. But alternatively, fatty acid metabolites are increased. And so the point of that here is that there's something happening at the level of metabolism that's not allowing for beta oxidation to occur of fats. And what we're seeing is increased fats in the serum and also acyl carnitine in the serum as well. So in other words, we're seeing that there's like a blockage, like there's an accident on the freeway and the cars are backing up into the bloodstream. And that's exactly what they're seeing here in post-COVID patients. So why would it be potentially that we're having a problem with metabolism there? They say here in the study, moreover, higher baseline levels of fatty acids and acyl carnitines are indicative of ongoing mobilization of fatty acids, but show impaired ability for oxidation due to mitochondrial dysfunction. Importantly, these signatures have been observed in patients with type 2 diabetes and sepsis, both pathologies that stem from metabolic and mitochondrial dysfunction. So it could very well be that in the electron transport chain, where there's a lot of oxygen moving around and electrons being oxidized, that there is reactive oxygen species that are not being taken care of, especially in these patients who are susceptible to getting COVID-19. And it's oxidizing the things that are supposed to be oxidizing the fats. And that seems to be at least one theory. Why do I tell you this? Well, because the scientists now are believing that melatonin, which is a very, very strong antioxidant, is produced in the cells of your body, of your skin, and this actually can reduce oxidative stress. So there was a study that was done. Let's go back here and look real briefly here. Angiotensin 2 is a pro-oxidant in your cell, and it gets reduced to angiotensin 1,7. That is done by the ACE2 receptor. But what happens? So pro-oxidant is going to increase reactive oxygen species. Antioxidant is going to reduce reactive oxygen species. The thing that's maintaining the balance in your body is this ACE2 enzyme. But guess what? The SARS-CoV-2 virus actually binds ACE2, knocks it out of production, and that's going to add to the reactive oxygen species. So as more and more cells are infected, reactive oxygen species get increased. Well, how do you reduce reactive oxygen species? Because that's important, because that can lead to blood clots and hypoxemia when you damage the endothelium. Well, melatonin is secreted from the pineal gland at night and directly mitigates reactive oxygen species. Another reason why we need to get to bed, another reason why we need to get sleep, it's because to fix the mitochondria that we've got to first prevent further destruction. There seems to be some indication that sunlight through near infrared radiation can also produce melatonin during the day. So getting outside and getting a lot of sun exposure is important. So what evidence do we have that reactive oxygen species is exactly what's going on in COVID-19? Take a look at these studies. Looking at intracellular glutathione, which is an antioxidant. Notice that across all age limits here, in COVID, it's lower, okay? This is an antioxidant, and it's lower in COVID across all age groups. What about measures of oxidative stress? In COVID, across all age groups, it's higher. These patients are worse off. And then what about F2 isoprostane? That's a measure of oxidative damage in the cell. Again, across all age groups, it's higher in COVID-19. So what I would say based on this, and I don't have randomized controlled trials. I'll tell you when I don't know. I really don't know for sure, but I think that the benefits outweigh the risks. If in fact that we know that reactive oxygen species is potentially damaging processes in the body, then maybe we ought to work on ways of reducing oxidative stress. And I think one of those ways is stuff that's really simple. You don't need a prescription. You don't need to go to a doctor necessarily or even get a test. These are things that we can do and educate physicians as well that, hey, let's get back to basics. You know, only 7% of the time in our country that we spend is spent outside. And that used to be 50%. And in other countries that don't have these issues that we have, they spend more time outside and they get more sleep because they're not affected by all of this light at night and social media and computers and all of this technology that we have. And maybe it's great for getting our work done, but maybe it's not great for getting our body situated to enjoy life. So, and I'll just throw this out here. Did we used to practice this as medical doctors? Absolutely. These are photographs of hospitals over 100 years ago. This is the mainline treatment for instance, tuberculosis. If you go in the Northwest, in Seattle, I had a friend of mine who was a neurosurgeon. She trained at a hospital in the Northwest, which was a pretty old hospital. They had a solarium. People used to get outside under the glass and get sunlight and sun exposure. And I really think that we may be missing on technology that's over 100 years old because we just don't realize that getting out, getting sun exposure, getting light, getting sleep are really, really powerful things that we can do, especially if we're suffering from long COVID. I think that's a perfect recipe. In fact, I published a paper with Margaret Skushlet, who's a professor in Mexico at the National University there. And in fact, what it showed in that study was that mortality to COVID-19 worldwide in those countries where BMIs were very high was associated with latitude. In other words, the closer you were to the equator, the lower the mortality from COVID-19. And what do we notice? Every winter, we see increases in flu, we see increases in RSV, we see increases in COVID-19. I don't think that's by chance. I think that there's a reason for that. So with that, we flew through things real quickly there. I'm going to stop sharing the screen and I'll pop back up here. But if there's a question where I need to refer to that, I may point it back up, but I'll open it up for questions.
Wow, that was amazing, Dr. Schwelt. You are brilliant.
Oh, I work with brilliant people, so I have to say.
Well, you're brilliant and modest. Okay. Okay, we've got a couple of questions. Actually, two of them are from me. So Soteria, I guess you can start off, and we want to encourage the rest of you though to enter in some questions here, because here we have the expert with us. So let's take advantage of it.
Okay, I'm gonna go ahead. Oops, where did we go? Hang on, sorry. I just had it up. Okay, if a patient was never aware they had COVID or were perhaps asymptomatic, yet experiencing what seems to be long COVID-like symptoms and other causes, clots, etc., are ruled out, is there any way to confirm that it is actually long COVID? Not really?
So that's a good question. I think the only way out at that point would be to get antibodies against the nucleus. So there's something called the core antibody that you can check for, and it's going to check for something different than what you would have gotten if you happened to have had the vaccine. Obviously, if you've never had the vaccine, then you could just check for regular antibodies, and if it's positive, then you know that you've had it. By the way, this is also very important. If you ever think that you have COVID, it's extremely important that you get tested. And the reason is that if for some reason down the line, the government or your work comes up with programs for long COVID, they're going to want to know that you had a documented infection. And so if you come down with long-term COVID symptoms, and you don't have documentation of that infection, that's going to present to you a problem. So make sure you get tested.
Well, Dr. Schwelt, let me jump in here since I asked that question. That's a really helpful answer. But with the testing, when they so often they seem to not be as accurate maybe as we would hope. So what if there's repeated, it comes up negative? So
you're talking about like home antigen testing. Yeah, home antigen testing is not sensitive. It's I can't even compare it, because home antigen testing is not testing to see whether or not you have had COVID-19. It's actually testing to see if you're infectious, because it's looking for the proteins. So if you are concerned about whether or not you have COVID-19 or have been infected with SARS-CoV-2, you really ought to be getting a PCR test. Okay. And so I'd recommend getting a PCR test. Don't just depend on the home antigen. The home antigen test is a way of changing behavior, not making a diagnosis.
Okay, thank you.
Mm. Okay. With long COVID being categorized as a disability by the ADA now, have you seen any changes or adjustments in the way treatment is provided or covered? What exactly does the classification enable providers to do differently with long COVID, if anything?
That's a good question. I have not seen that trickle down yet. I know I was just made aware that it's made now as a diagnosis and therefore a disability potentially. But in terms of things in my area, which is the same, I imagine, as your area now, since we're talking San Bernardino County, I have not seen programs or things of that nature come up. I would love to be able to put together a program based on what we've talked about here and also the latest evidence for people. And I think as more and more people are exposed to the virus and are having these issues, I think it's going to be more needed. But to answer your question, I haven't seen anything yet.
Oh, very good. Could the hair loss happen before or after the 3 months after infection?
It could, if you might have been infected before that you knew it. But generally speaking, and it depends on the clock and the depends on your biological clock and how things move quickly. But generally, it's about 3 months, and I would say plus or minus 2 or 3 weeks.
The next one, regarding OT, would you state that the ENTs in our area were utilizing this therapy prior to the COVID pandemic? If so, may you repeat the optimal time frame to begin this therapy to restore sense of smell?
I don't know of a single ENT that was doing olfactory training, as far as I'm aware, not even in my own clinical practice. They may have been doing it. I hadn't seen them doing it. I didn't even know about it until after COVID-19. And I would say that the most optimal time to start is right away. The earlier on this, the better.
Very good. Dr. Hansen, he joined late, but but your thoughts on the potential for immune mediated inflammatory response as a mechanism to long COVID due to retained viral proteins and not just mimicry.
Yeah, no, it could very well be. That's one of the theories. I think it's a legitimate theory. I think there's other theories too, and I think what will probably happen, just like when we talk about chronic cough could be related to postnasal drip, cough variant asthma, and gastroesophageal reflux disease, and we usually treat all three of those things. I think that long COVID is going to be a combination of post-inflammatory responses and also the virus hanging out, and probably oxidative stress issues as well. It's probably not going to be a clear-cut thing.
Also, comments on utilization of steroid trials with associated aspirin use for this purpose?
Yeah, so that would go along more with the blood clots. So we're seeing blood clots, and not your typical blood clots with COVID, that you would normally have that are rich in fibrin and proteins. These are platelet-rich clots that we see, and that's why I believe the aspirin is being involved there as well. To the degree that that's the issue, then that could very well work. This was looked at very early on in COVID when they started seeing these platelet-rich or white clots. I think we need to see the studies, but it'll be interesting to see.
What can we tell our doctors that keep treating and giving medicine for asthma if we believe it might be long COVID?
Well, it could very well be asthma too, as it relates to COVID. What I would say is if you're going to treat something, make sure that you are diagnosing it correctly. So if you do believe that this is asthma, make sure you've got evidence like a pulmonary function test, and if not, even a methacholine challenge test, because that will show reactivity. Now, it could very well be that the increased reactivity is post-viral. But that doesn't mean that we don't treat the asthma that we're seeing there as well. So it could very well be that we've got to treat the asthma on a temporary basis until we get to the underlying cause, because if we don't treat asthma, that could lead to pretty severe consequences.
In elderly patients that had previously articulation affections, do you know any cases that can be worsened by long COVID? I do not. Oh, they said, I don't know. I do not know if my question makes any sense.
What was that for articulation? Is that what they put? Articulation? I'm not sure. Yeah.
Articulation
Yes.
affections. That's what it says.
Articulation, like where a bone meets a bone. So like a joint, it's possible. I've seen so many
like
things.
a joint. Sorry, that is me. So I'm sorry. So I will justify myself saying that English is not my main language. So
No, I mean, you said it exactly correct. You said it exactly correct. Articulate. I know exactly what articulation means, and that's exactly what you meant. So that's
I
good.
didn't know what it meant.
Yeah. So that's where a bone. So articulation is where a bone meets a bone. So that would be a joint. Exactly. I have not seen that unless we're talking about, in terms of an infection or like a septic joint. I haven't seen that. It could very well be flaring up an autoimmune condition, which could cause like a rheumatoid type of arthritis, if that's what you're referring to. I have not seen that, but interestingly, there was a study that was published out of Harvard that showed that vitamin D supplementation on a regular basis actually reduced all-cause anti-inflammatory reactions. This was just published this last year, and they supplemented these patients for a couple of years. It was part of a study looking at vitamin D supplementation and cardiovascular disease. What they found, it wasn't an a priori endpoint, what they found as part of that was that autoimmune conditions reduced in those that supplemented with vitamin D. So vitamin D is well known to be an immune modulator. There are receptors for vitamin D in white blood cells. And we obviously know about the effect of vitamin D on bone metabolism, but we're now just starting to understand a little bit more about immune function of vitamin D as well.
thank you for that. And I have another question that is kind of similar to that one.
Yeah, sure.
So my husband had chikungunya when he was in our country, and then when he came here, he got COVID. So after that, the flares with the chikungunya had like kind of potentiate, and I don't know if if it is related just because it was like kind of two viral infections, but one that never goes away and the other one that kind of does, or it could be just another consequence.
Well,
Just curiosity.
Yeah, you bring up a very good point, because I didn't want to get into this because there's a whole nother area of this, but there's a study that shows that in long COVID patients, Epstein-Barr virus has been implicated as being elevated as well. And so here's an idea where maybe the immune system is spinning plates by keeping these other chronic viral infections under wraps. And then this comes along and the immune system is distracted, and maybe you get a zoster flare, or maybe your EBV pops up, or in your case, chikungunya comes up as well. So that's certainly a possibility. And I don't know if it's more complicated than that simple explanation or not. I think more research needs to be done.
And the last question, I'm probably going to botch up these names. It says, your comment on thromboxane and prostaglandin,
Yeah.
yes, D2 receptors is causing thrombosis, embolism, and intense deregulation of immunity, causing severe inflammation.
So thromboxane and prostaglandin, these are byproducts of the arachidonic acid pathway. And if you may recall, this is where aspirin works. So aspirin basically it's called a suicide inhibitor, and it prevents it. So these are parts of our normal inflammatory pathway. And I do believe that too much inflammation here is causing inflammation of the endothelium, and that endothelial inflammation is exposing the fibrin underneath, and that could be causing the blood clots. I certainly do believe that. I think there was very good evidence for that very early on, and I believe that von Willebrand's factor is one of those things that was mitigating that area. And so this is one of the reasons why I'm a big believer in reducing oxidative stress, because I do believe oxidative stress is what is tipping this stuff off. And it's also a very attractive theory, because oxidative stress is implicated in diabetes, which we know is a risk factor. It's also implicated in obesity, which is a risk factor. And also we know that our autoimmune conditions, our oxidative stress gets worse as we age, as I showed you in those graphs, that as we get older, we're more susceptible. So we have to try even harder as we get older to make sure that we're eating plenty of fruits and vegetables that have polyphenols and antioxidants in it. Anything that ends in the word berry is going to be very beneficial in terms of reducing inflammation.
I'm really interested in that last comment and your earlier explanation about the oxidative stress. Can I ask you, in addition to living a healthy lifestyle and eating properly and getting exercise and all those good things we need to be doing, especially as we get older, are there any additional things that you believe we should be doing, or supplements we should be taking to reduce this oxidative stress and inflammation?
Okay, so in addition to all of that, there is one research paper that looked at taking supplemental NAC, which is N-acetylcysteine, at 600 milligrams twice a day during the winter season, and it did not reduce the incidence of the influenza virus, but what it did do was it reduced the severity of the impact of those who actually got the influenza virus, so that they didn't miss days. I thought that was an interesting study. That was done a number of years ago. And it was just through a winter season that they did that study. So NAC, which is an antioxidant, is beneficial. But, I'm a big believer in natural antioxidants, because I think they get packaged very nicely. There was a study I'll just briefly share with you. When we were looking at this for lung cancer, we found that people who had high amounts of vitamin E and vitamin C in their diet had better survival for lung cancer. So what the scientists did then was they isolated vitamin C and vitamin E, and they gave it in high doses to people with lung cancer. Guess what the result was? Those people had higher incidences of mortality than those that didn't. And so here's the point, is that I believe that these polyphenols and these antioxidants are perfectly packaged for our consumption the way they are naturally given to us. And I think that we shouldn't improve on nature by trying to package and package it. And that's my personal bias. I think that the best way to get melatonin is to get it from your pineal gland and be sleeping at night. The best way to get melatonin is to be outside in the day, if in fact near infrared radiation increases that. I think the best way to improve our health is to get the natural things that our bodies are used to doing, and not trying to improve on that first. Now, if you want to supplement, I myself take vitamin D. I don't spend enough time in the sun, so I'll take some vitamin D. I'll take NAC during the winter season if I'm concerned about getting the flu, but I'll also get the flu vaccine, which is what I did. And I also get my COVID-19 shot because, hey, I work in the ICU and I'm a high risk person for that as well. So I think we need to take the Swiss cheese approach which
No.
is that every slice with different holes in it are a way to block those particles. And the more things that we do, the better. You know, in the operating room, we don't say, hey, let's just go ahead and wash our hands and put gloves on. And that way we won't have to sterilize the equipment. Or, hey, why don't we turn off the positive pressure? Then we won't have to like wear masks. No, we do all of that because we want to prevent any infection. Any infection in the OR is one infection too many.
Wow, that's
Very
really,
good.
really fascinating. Well, gosh, thank you so much. And we have a lovely thank you from Dr. Hansen and from Mayra as well. And I know everyone appreciates everything. Dr. Hansen included a kitty cat with his. I just wanted to point that out. Thanks,
Mhm.
Dr. Hansen, for doing that.
Mhm.
Dr. Schwelt, that was just really, really fabulous. We'd love to have you back for one of your future, you know, when you're ready to present new aspects on this or however you know, your evolution proceeds on this, on your studies. And we would like to ask, are you comfortable having us share your slides with the
Oh,
group?
absolutely. Yeah, I'll email it over to you right away.
Wow, we appreciate
Great.
that.
Thank
Okay,
you.
so we will send that out to everyone with a recording of
Mhm.
today, and so you can share that with colleagues for some of the folks who may have missed out. And thank you again so much, and we wish all of you happy holidays. We're getting close to the holidays, so thanks everyone for joining. Thanks, Dr. Schwelt, for all your expertise. Be sure to check our
Thank you.
SBCMS Facebook page, please, for wonderful updates and event information like this, future webinars. All right, everyone. Thank you. Thanks, Dr. Schwelt, once again. And thanks everyone for joining, and we'll see you soon.
Thank you.
Bye.
Thank you.
Thank you.